Our second speaker is really well, I don't know this. Dr. Sridharan Raghavan. Dr. Raghavan actually received his Bachelor of Science from MIT, followed by a PhD and MD at UCSF. He did his residency at New York Presbyterian Hospital and Columbia University, followed by a fellowship and a master's degree in public health at Harvard. He came here as a faculty member in 2015 and currently is an assistant professor in the Division of Hospital Medicine. And today, Dr. Raghavan is going to talk to us about genetic insights in diabetes complications and in clinical biobanks.
Thanks everyone for bearing with us. So I'm going to talk a little bit about diabetes complications and also a little bit about EHR-based clinical biobank research, sort of quickly all together. By way of outline, I'll give a crash course in sort of diabetes and how I think about it, and also talk a little bit in that conversation about sort of pros and cons of EHR-based and clinical biobank research, and then go over one example looking at association of diabetes with dementia, which is probably not a typical complication that we think about for diabetes, and then have a concluding thought. So just in terms of diabetes in a nutshell, there's sort of in the period before someone's diagnosed with diabetes, there's sort of a pre-diagnostic period that can span years or decades, and sort of during that period, there's sort of accumulation of risk factors, insulin resistance might progress, loss of insulin production from the beta cells in the pancreas. These are sort of things that are happening physiologically that we measure as sustained glucose elevation. And sometimes a person might meet criteria for some labels like metabolic syndrome or prediabetes. And in terms of clinical care, we sort of have two things that we're doing clinically. One is sort of varying our surveillance practices based on a person's risk potentially, sort of the frequency with which we measure hemoglobin A1C, which is our diagnostic measurement in contemporary practice for diabetes. And then we might recommend preventive interventions focused on a lifestyle modification. And actually, I included a couple of drugs because in the modern era, there are a couple of drugs that seem like they might be particularly beneficial as well. When a person finally progresses to meeting the criteria for diabetes, and one of the early things we might think about doing is trying to figure out if we can classify them, and the sort of a simplistic approach would be to classify a person as type 1, type 2, or monogenic diabetes. There are other forms as well, and there are a number of lab tests that might help discriminate between these, and those have important implications because they can dictate early treatment. After diabetes diagnosis, however, things get a lot more complicated, and they sort of, again, have sort of natural history in the middle, how we might think about classifying a person during their progression through the disease, and then things we do clinically on the bottom. And so in terms of what happens after you acquire a diagnosis of diabetes, usually a provider will make some recommendations with the goal of reducing measured glucose. That's usually the lever that we're targeting, though, again, in contemporary times, there's sort of drugs that might have benefits even without lowering glucose as much. So, but historically, we thought about glycemic control or glucose control as our lever for preventing complications, with good or strong early glycemic control associated with delays in complications, and I'll talk about that in a second, whereas poor glycemic control early is associated with earlier development of complications. And so the complications that we think about are usually in two broad categories, microvascular and macrovascular, and microvascular being runs of kidney, eye, and neuropathy, and macrovascular being cardiovascular disease, so heart attacks, strokes, and peripheral vascular disease. So those preventing complications is sort of like the main goal of diabetes treatment, and glucose measurements being our sort of measurement the biomarker that we use. And that changes over time. Over the course of the natural history of a person who has diabetes, clinical care recommendations might suggest being more aggressive early when a person has fewer complications, and less aggressive as complications accrue, because there are often side effects of medications and other risks associated with people with more complications. And then the other big part of treatment is cardiometabolic risk reduction, and that's really blood pressure control, lipid control to reduce cardiovascular disease risk. And then the two, sort of in terms of treatment, we have sort of two levers: choosing a specific medication, and those can work across a number of different mechanisms, and then the intensity, which we, again, usually index by hemoglobin A1C or glucose levels. And then the other thing that happens in clinical care is over time, we start to think about disease prognostication, specifically predicting risk of complications or risk of adverse drug events, both of which have implications for treatment choice and treatment intensity. So that's sort of like diabetes care in a nutshell. So moving into like studying diabetes and diabetes complications, I think an important thing to just make clear is that this is all a years or decades long process. So up to the point of diagnosis with diabetes, that can be years or decades. Type 2 diabetes in particular is typically a disease of adulthood, and so there's been decades of life course before that. And then having diabetes to the point of having extensive complications is also many years to over a decade process on average. And so, and one sort of theme of this talk will be that while cohorts with healthy volunteers, which are our mainstay of epidemiologic research in the US and internationally over the last sort of 70 years, are really good for understanding risk factors and progressions in the pre-diagnostic period, up to the point of disease diagnosis. However, even a disease like diabetes, which has a 10% prevalence and is very common, if you have a cohort with 10,000 healthy volunteers, only 1,000 of them progress to having diabetes, and so your ability to study diabetes complications is severely reduced. And so, in particular, when there's a lot of other things happening over the course of the disease course with diabetes, it becomes extremely hard to sort of assess causal relationships between exposures and events that occur early in the disease course here on outcomes that occur years later. That can grow to be very challenging. And so I think that one sort of takeaway that I hope I can convince you of is that to do that kind of research on diabetes complications requires cohorts of diseased individuals who are followed longitudinally, and the natural place to find that is in clinical biobanks or EHR-based data. The limitations of EHR-based data are sort of cons to it, mostly related to data quality and missingness, which tend to be a lot better in prospective cohorts. But there are other advantages, particularly the ability to study with adequate statistical power complications as they develop. So that's sort of a crash course and sort of why I think this is an interesting problem, and particularly an interesting problem for use of clinical biobanks. And I'll talk through one example in detail now. So diabetes and dementia are both high prevalence conditions. Just again, these are both sort of modified quotes taken from the Mayo Clinic's patient-facing website. So diabetes mellitus, so we're all on the same page, is an impairment of the way the body regulates and utilizes glucose, and that can include impaired insulin production and insulin responsiveness, which has other effects besides on glucose levels. And then dementia is a group of symptoms affecting memory, thinking, and social abilities severely enough to interfere with their daily life. And on the left here is a table with numbers from the CDC from a few years ago that in older adults, I can't remember exactly, I think it was over 70, but I'm not 100% certain, the prevalence of diabetes and dementia. So in both cases, over 10% of the population over age is at risk or has diabetes or dementia, and that's pretty consistent across race ethnicity groups in the US. And I should say that all of the rest of the presentation focused on diabetes and dementia. So Liz Litkowski, who's an extremely talented PhD student. We just finished her dissertation last week, actually. So diabetes is associated with a 1.5 to 2-fold increase in the relative risk of dementia, and that's raised the possibility that perhaps diabetes is a causal risk factor for dementia. So I'll show figures from 2 papers that explore this in a little bit more detail. So this is a study from almost 10 years ago now that attempted to build a risk score for dementia. And you can see that, I'll just point out that cholesterol, BMI, systolic blood pressure, and sex are all risk-raising factors for dementia, and all of those are also risk factors for diabetes. And so there are a lot of common risk factors for the 2 conditions, and in this study, they actually added diabetes as an independent variable in the dementia prediction model, and it didn't improve model performance. So that raises this question of whether it's just shared risk factors or whether diabetes itself has a causal role. On the other hand, the same group, using a different data set, developed a risk model for people with diabetes for predicting dementia risk. And here, and sorry if it's a little bit unclear, but in this middle box here are listed a number of complications related to diabetes itself. So while in the prior study, adding diabetes as an independent variable didn't improve risk prediction for dementia, among people with diabetes, age and education are still risk factors, but so are a number of diabetes-related complications, and the higher you score on the x-axis, the greater the percent risk of developing dementia among people with diabetes. So that brings us to sort of different possible pathways. So one is that diabetes has a causal effect on dementia, and there are shared risk factors as well as unmeasured confounders that influence how we quantify that association. But it's also possible that diabetes isn't causally related to dementia, and that association is purely due to unmeasured risk confounders, and that would also fit if the problem was with the second study that showed that there was an association between diabetes complications and dementia, because many of the same risk factors and other confounders that are associated with diabetes may be associated with diabetes complications. So why does this matter? I think there are potential implications for prevention, where diabetes prevention, rather than just risk factor modification, might be beneficial over decades for dementia prevention. And then similarly, among people with diabetes, whether there are implications for treatment choice and treatment intensity to reduce dementia risk. Again, not a complication of diabetes that we typically think about when we decide on treatment. And so the main question that we're going to try to address is whether there is a causal error that connects diabetes with dementia. So can genetics help? So there have been a number of genome-wide association studies for both diabetes, type 2 diabetes, and as well primarily for Alzheimer's disease in the dementia world. Over 300 diabetes-associated variants and GWAS that exceed 1 million for type 2 diabetes. A little bit smaller for Alzheimer's disease, but a number of loci. There aren't very many, if any, shared genetic variants except for one, and that's the ApoE locus, which is the strongest variant associated with, or locus associated with Alzheimer's disease. Also happens to be genome-wide significant associated with type 2 diabetes, but in the opposite direction. So this one locus that has a shared association in GWAS has opposite directions of effect, which would argue against sort of a shared pathogenesis. Other studies that have looked at the causal association of type 2 diabetes with Alzheimer's disease have been mostly negative, but they have a few limitations. One, they're mostly in European samples. They depend on existing GWAS data and don't have individual level data on the participants themselves, and mostly limited to Alzheimer's disease among the different dementias. And they're mostly enriched for samples, as I said earlier, with healthy volunteers. So there are very few incident dementia cases in most of these samples. So our aim was to examine the causality and association of diabetes with dementia in a multi-population clinical biobank that I'll tell you more about in the next slide, and that captures other dementia outcomes in addition to Alzheimer's disease. So not limited only to that one form of dementia, but more broadly, and using a genetic epidemiologic method called Mendelian randomization, which I'll tell you more about as well. So the biobank that I'm going to tell you about is the Million Veteran Program. It's a cohort of U.S. military veterans enrolled at over 60 VA medical centers. For just over 10 years now, they're trying really hard to hit their million goal before the end of 2022. They're close. At the time that we did this study, there were over 700,000 individuals with genetic data and about 180,000 with had diabetes at the time when they enrolled in MVP. And it's a national study. Denver had a site that closed, I think, about 5 or 6 years ago. But there are veterans recruited from all over. And the types of data that are there, and happy to talk more with anyone who's interested, include clinical data from the electronic health record, at least back to 2002. There's a phenotyping cohort that develops and validates algorithms for some specific traits of interest. There's some text-based outcomes like ejection fraction has been claimed and is available. And then there's a baseline lifestyle survey, including diet, physical activity, and other health behaviors in about half of the participants. They did genotyping in all these individuals on a custom mathematics array with SNPs imputed to the 1,000 genomes reference panel, and there's custom content that was targeting cardiovascular disease risk and drug metabolism. Not available are some things that are not routinely collected in a standardized way nationally within the VA, such as EKGs, pulmonary function tests, path reports, and endoscopy findings. So back to this. So this is the goal is to study this complicated set of arrows. And just for simplicity, this is really the 3-factor relationship that we're trying to understand better in this study. So Mendelian randomization is a genetic instrumental variable analysis for those for whom that means something. Essentially, the goal is to take genetic risk of type 2 diabetes, of your exposure of interest, and use that as an instrumental variable or proxy to assess associations with dementia. Genetic risk is attractive because it's randomly allocated before any environmental exposure, during meiosis, before you're born, long before you're born. And so it's relatively immune to unmeasured confounders, so risk factors potentially affecting your genetic risk of diabetes. And so that makes it sort of attractive as a tool in this type of analysis. And so the goal is to estimate diabetes risk. And so if the diabetes risk predicted by a person's genetics is associated with the outcome, in this case dementia, that suggests evidence of a causal association. And I'll talk through that a little more in the coming slides. Important assumptions that can't be violated for this method to work. One is that you do have a strong genetic instrument, that you can create a genetic proxy for diabetes risk, and that it's a strong association. That your genetic risk isn't associated with the risk factors or other unmeasured confounders that you're trying to leave out of the analysis altogether. Again, that's a difficult to impossible thing to verify, but there are some ways to address that concern. And then finally, the notion of genetic pleiotropy, where either composite genetic risk or a single variant were associated with both diabetes and dementia through different pathways, then you would violate an important assumption where you might see an association through your Mendelian randomization study, but it's not due to diabetes, it's actually due to an independent pathogenic effect of a genetic variant.
That's a quick question related to that. Given that high glucose can be neurotoxic in and of itself, leading to differences in LTP and cognitive function, how do you stratify for just a glucose effect?
So one thing you can do is you can substitute wherever it says diabetes with glucose, and you can substitute a genetic risk score for diabetes with a genetic risk score for glucose, because we have GMI association sites for glucose. So you could do that to look at a glucose-specific effect that's not related to diabetes. And then the other thing that you can do is this is a simple approach, but there are also multivariable approaches to doing this type of a study, where you can include genetic variation for glucose and or directly measure glucose to address some of those issues. So the way we did it, there are multiple Mendelian randomization methods. The one we took is called a two-stage least squares regression, and that happens in 2 steps, and I'll walk through those now. So in the first step, we generated genetically predicted diabetes instrumental variable. So we regressed diabetes as the outcome, that's X1 here, on the diabetes genetic risk score, and I'll tell you more about the risk score in a couple of slides. And so G1 is our genetic instrumental variable. And then we use that regression equation to estimate for every person in our population the predicted probability of diabetes. We'll call it X1 hat. So that's a genetically estimated risk for diabetes. And then you can see now that once we have that, we're now going to, in step 2, look at the association between that genetically predicted type 2 diabetes and the dementia outcome. So Y being dementia, and now you're putting in X1 hat of the genetically predicted diabetes risk, and you're no longer looking at whether a person actually had diabetes or not. And so then by doing so, you sort of remove the contribution of risk factors and unmeasured confounders in theory. One important caveat of this is that this really is best for providing a yes-no answer to the causal question rather than a quantitative estimate of what the causal association is, because we're really looking at genetically predicted type 2 diabetes risk, not yes or no, does the person have diabetes. So a few definitions. So for the genetic risk score for type 2 diabetes, we use 330 variants from a genome association study. So these are all GWAS significant from recent GWAS, and we use a weighted score. So we added up the number of risk alleles carried by each individual at all 330 of these loci, weighted by their strength of association with type 2 diabetes in the GWAS. And so we call that GRS 330. Diabetes we defined using EHR data, again, 1 inpatient or 2 outpatient uses of ICD codes for diabetes, and the use of a diabetes medication prior to MVP enrollment. And for dementia, I'm not going to include a table with the different ICD codes, but we require 2 uses of an ICD code from different encounters for any dementia for our all-cause outcome, and for codes specific to Alzheimer's disease or codes specific to vascular dementia for those respective outcomes. And these were not mutually exclusive, as I'll show you in another figure. And we adjusted for age, sex, and 10 genetic principal components. And we stratified by race ethnicity, and we used something called harmonized ancestry and race ethnicity, which is an algorithm developed in MVP that uses both self-report and genetic ancestry to infer race ethnicity. On the left here is just our participant characteristics. So we had about 250,000 people. We only included people over age 65, so the average age is obviously is higher than that. Almost all men. You can see a little over 7% had dementia of any kind, and 1 to 2% had either vascular or strict Alzheimer's disease. And our diabetes prevalence was over 20% in all three race ethnicity groups. So almost double or more, or triple what we see in the US population. On the right is a figure that just shows the different outcome diagnoses. So, and it is to scale. So the green represents all-cause dementia, and many fewer with either strict Alzheimer's disease or vascular dementia. And you can see there's about a 20% overlap. So I'll walk through each of these steps that we're going to go through in the analysis. So for step 1, we regress the diabetes, whether a person has diabetes or not, on the diabetes genetic risk score, and then we generate a predicted probability of diabetes based on that first step. And so I'm just showing here for each of the race ethnicity groups. On the x-axis, the predicted probability of diabetes, which is a value between 0 and 1, and as a histogram in people who did not have diabetes in red and who did have diabetes in blue. And you can see, you would think that these histograms are largely overlapping, but this is actually a sufficient shift to the right that's highly significant. So the genetic risk score is significantly associated with diabetes in all race ethnicity groups, with an odds ratio over 1.28 per standard deviation increase in the genetic risk score, and the p-values are highly significant. So we have a reasonable way of estimating genetically predicted diabetes risk. So for the second step, we regress dementia on that genetically predicted diabetes for each individual in the sample. And so I'll sort of do this one step at a time. So here we categorize people into quartiles of genetically predicted diabetes risk, with the lowest quartile here being the reference. And so relative to the reference, each quartile increase in genetically predicted diabetes risk increased an individual's risk of all-cause dementia. You can see sort of a graded response here for all-cause dementia, and a similar pattern for vascular dementia. Now, there are many fewer cases of people with vascular dementia, and so our confidence intervals are wider. And then similarly, a graded response to Alzheimer's disease. Again, the confidence intervals are a bit wider than for all-cause. And so we see a graded dose-dependent association of genetically predicted diabetes risk with each dementia outcome, but the strength of the association seems actually qualitatively stronger for vascular dementia than for Alzheimer's disease. And so this is in our non-Hispanic white population. If we look in our non-Hispanic Black population, we don't see that same genetically predicted, that graded response that we had in the larger sample size that we have with in the non-Hispanic white population. We still do see an association for all-cause dementia and for vascular dementia, but not necessarily as clear for Alzheimer's disease. So the graded response is less clear, but the overall association of genetically predicted diabetes risk with all-cause and vascular dementia seems to be preserved in this population. In the Hispanic population, all of the associations cross null. And mind you, this is the smallest sample of the fewest individuals with dementia. So I mentioned these assumptions that are critical to test, and so I'll just quickly talk through 2 of them. I won't talk about addressing unmeasured confounders today, just in the interest of time. So for the strength of the genetic instrument, we use something called the F statistic, where the sort of convention that states that the F statistic over 10 indicates a strong instrument. And again, this shift in the curve was correlated with an F statistic of over 57 in each of the 3 populations. So we have a strong genetic instrument. And then the issue of pleiotropy we address again through other methods. As I mentioned, there's a number of molecular randomization methods, and I just cherry picked one example here where we use a score with 330 SNPs. As I mentioned earlier, the ApoE locus has divergent directions of effect on diabetes and dementia. If we do the same analysis with that additional SNP to make it a 331 SNP score, you see a very strong heterogeneity p-value, which indicates, again, that potential for pleiotropy. And so sort of a positive control that if we include that known pleiotropic SNP that we observe pleiotropic results. So in conclusion, I think for this blue arrow with the question mark, at least in the non-Hispanic white population, we feel like we have evidence that diabetes may be causally associated with dementia. But with some important limitations, it's almost exclusively men. We didn't assess sex differences, and there's somewhat inconsistent association for this scheme. There's a few different potential reasons for that, but we haven't explored those yet. And we haven't addressed your question, which is really the other glycemic traits which we could interrogate and mediate some of this. And then other implications, though, I think going back to what I mentioned earlier, why do we care about this? I think I think these are areas of intense research interest now, is whether diabetes prevention impacts the dementia incidence and whether specific treatment choices or intensity in people with diabetes might impact dementia outcomes. So the last concluding slide, I'll just sort of come back to this and make the case that, in this setting of a years-long process with a lot of intervening clinical events and sort of natural physiologic events, doing causal studies is challenging, and high-quality EHR-derived data is essential for this, and particularly for studying treatment-related effects in real-world settings. And I didn't talk about that today, nor did I talk about sort of in the context of a health system such as ours, understanding population-specific effects that might be relevant to precision medicine and precision health within a population, within a health system. But then today we really focused on disease complications that might be underrepresented in unselected samples, but in selected samples of individuals receiving clinical care, we can really study them better. So thanks to funding, and really again, all of this was possible because of the great work of Elizabeth Witkowski, and who was primarily mentored by Nathan Lang in the Department of Medical Informatics, and then close collaborators in the MVP, thanks to MVP participants, of course, and a lot of the core teams as part of MVP.
Thank you. Any questions? So in your criteria for selecting the folks for inclusion, they had to have a code indicating diabetes, a clinical code, and also at least one medication. These folks were recruited over a long period of time, and their traditional care of diabetes, which is different from now, was start off with diet and exercise, and we sort of added one. We accelerated. Now we sort of start here and do this. So whilst you try and remove the effects of these external environmental factors and medication, the amount of years and the types of medications used could actually affect dementia outcomes. So how do you get around affecting your secondary disease outcome based on those intervention factors in between?
So we don't address that here. One could, in theory, sort of similar to the other question, you could come up with ways to include other covariates if you were worried about that. You would want to sort of have a reason to think that a person's genetically predicted diabetes risk correlated with one of these other factors that comes after the diagnosis, which I think is totally plausible. That could also affect dementia risk. If you could construct that model and you thought that was possible, then I think you could include other variables. So one of the other things I didn't talk too much about is that with these biobanks, you actually have individual level data. So we could, in theory, we know who got metformin, we know who got sulfonylureas. We could, in theory, add other medication variables if we wanted to, but not everyone was treated, right? So we didn't limit our study to people with diabetes. And so there will be people who are untreated. So I think that to address treatment-related questions, we would really focus on people who have diabetes, and then and then there are genetic instruments for treatment as well. So we could start to look at, there are genetic loci associated with metformin use or metformin response, and so we could do similar studies with that.
Probably a naive question, but is there evidence that tight glycemic control relates to a slower progression of cognitive decline?
I don't think so. So it's The short answer is I believe the answer is no. Probably the best study to look at that in was unfortunately the UK PDS trial, which enrolled people who were newly diagnosed. It's pretty small, and the glycemic control effect really, like the nadir A1C was within the first 12 to 18 months, and then sort of drifted up after that. So it's not, I don't think we don't have great data for it. That has been looked at in another trial where people were enrolled on average 8 to 10 years after they were diagnosed, and they were randomized to intensive versus less intensive treatment. In the context of that trial, there wasn't an association with cognitive outcomes, or certainly not diagnoses, like hard dementia outcomes. But those people also had already had conventional care for a decade on average. And so it's really hard to know if the intervention at that time point was actually meaningful. And then maybe one for a follow-up on that is that in the diabetes prevention program, which is probably our gold standard trial for diabetes prevention, people were randomized with prediabetes and overweight. I think that, again, it's a relatively small study. I don't think that there was a signal yet for dementia outcomes, and they're about 25 years out now.
Actually, nice talk. The first question is about your two-stage regression model. What do you think about just doing one regression model, where you take the loci and then incorporate them directly into, so that it allows you to discover if there are only subsets of variants that might produce stronger association with diabetes?
I don't have a lot of thoughts about that. I think one could potentially do it. I do think that that's a slightly different model that looks at SNP effects on dementia rather than SNP effects. You're trying to identify the effect on diabetes, quantify the effect on diabetes as your proxy for outcome associations with dementia. That said, I think to your second part of that question, there are a couple of groups at least that have done sort of approaches to clustering variants that are associated with diabetes. So you can, and there are sort of different approaches to this, some that are mutually exclusive clusters, some that are non-mutually exclusive clusters, and they have different associations with glycemic or physiologic variables. And so one of the things that Liz and I have talked a lot about that we haven't done, we did look at insulin and glucose and A1C genetic variants, but that's a little bit crude. But you could look at different clusters of variants, and that's something that we could do, but that would isolate more physiologic pathways that might underlie this.
Cool. And then the other question is, do you have
We're
lots of...
actually at the top of the hour.
Oh,
We have
sorry.
another group coming in.
Okay.
I apologize. Thank you very much,
Yeah.
Doctor.